Today's topic of discussion is ascites. Definition: accumulation of fluid within the peritoneal cavity. Small amounts may be asymptomatic. Increasing amounts cause abdominal distension and discomfort, anorexia, nausea, early satiety, heartburn, flank pain, and respiratory distress. On physical examination, bulging flanks, fluid wave, shifting dullness, Puddle sign, that is dullness over dependent abdomen with patient on hands and knees, may be associated with penile or scrotal edema, umbilical or inguinal herniation, pleural effusions. Evaluation should include rectal and pelvic examination, assessment of liver and spleen, Palmer erythema and spider angiomata seen in cirrhosis. Periumbilical nodule, Sister Mary Joseph nodule, or supraclavicular node, Virchow's node, suggests an abdominal malignancy. Ultrasound and CT abdomen very sensitive. It's able to distinguish fluid from cystic masses. And evaluation: diagnostic paracentesis 50 to 100 ml is essential. Routine evaluation include gross inspection, protein, albumin, glucose, cell count, and differential. Gram and acid fast stains, culture, cytology. In selected cases, check amylase, LDH, triglyceride, culture for tuberculosis. Rarely, laparoscopy or even exploratory laparotomy may be required. Ascites due to congestive heart failure may require evaluation by right-sided heart catheterization. Differential diagnosis of cirrhosis: cardiac ascites, peritoneal carcinomatosis, and mixed ascites resulting from cirrhosis and a second disease account for 10 to 15%. Disease of peritoneum: infections, bacterial infections, tuberculosis, fungal and parasitic neoplasms. Connective tissue disease, miscellaneous, Whipple's disease, familial Mediterranean fever, endometriosis, starch peritonitis. Diseases not involving peritoneum: cirrhosis of the liver, congestive heart failure, Budd-Chiari syndrome, hepatic veno-occlusive disease, hypoalbuminemia, that is in nephrotic syndrome and protein losing enteropathy, malnutrition. Miscellaneous is myxedema in hypothyroidism, ovarian diseases, pancreatic diseases, chylous ascites. Classification is using serum albumin, ascitic albumin gradient. That is, the difference in albumin concentrations between serum and ascites is a reflection of imbalances in hydrostatic pressures and can be used to differentiate between potential causes of ascites. Cirrhotic ascites pathogenesis: contributory factor, portal hypertension, hypoalbuminemia, hepatic lymph, renal sodium retention, secondary to hyperaldosteronism, increased sympathetic nervous system activity, renin-angiotensin production. Initiating event may be peripheral arterial vasodilatation triggered by endotoxin and cytokines and mediated by nitric oxide. So this is the SAG chart. If SAG is more than 1.1 gram per deciliter, we have to go for ascitic protein, and ascitic protein if less than 2.5 gram per deciliter, cirrhosis, late Budd-Chiari syndrome, massive liver metastasis. While if ascitic protein is less than 2.5 gram per deciliter, congestive heart failure, constructive pericarditis, early Budd-Chiari syndrome, inferior vena cava obstruction, sinusoidal obstruction, and if serum albumin ascitic gradient is less than 1.1 gram per deciliter, there is a biliary leak, nephrotic syndrome, pancreatitis, and peritoneal carcinomatosis. The algorithm of SAG. Treatment of cirrhotic ascites. Rigid salt restriction, that is less than 2 gram per sodium per day. For moderate ascites, diuretics usually necessary. Spironolactone 100 to 200 milligram per oral can be increased up to 400 milligram per day if low sodium diet is confirmed and fluid not mobilized. Furosemide is up to 80 milligram per day per oral or IV may be added if necessary. Greater risk of hepatorenal syndrome, encephalopathy can increase to maximum up to 120 to 160 milligram per day furosemide until effect achieved. Monitor weight, urinary sodium, potassium, serum electrolytes, and creatinine if ascites is still present with the above measures. This is defined as refractory ascites. Now, what is the treatment of refractory ascites? Pharmacologically, add midodrine or clonidine to diuretic therapy, repeated large volume paracentesis with IV infusion of albumin 6 to 8 gram per liter ascites removed. Consider transjugular intrahepatic portosystemic shunts. While TIPS manages the ascites, it has not been found to improve survival and is often associated with encephalopathy. Prognosis with patients with cirrhotic ascites is poor with less than 50% survival in 2 years after onset of ascites. Consider liver transplant in appropriate candidates with the onset of ascites. Complications: spontaneous bacterial peritonitis, the ascitic tape in which polymorph nuclear cell count is more than 250 per microliter, confirmed by positive culture, usually E. coli and other gut bacteria. However, gram-positive bacteria including Streptococcus viridans, Staphylococcus aureus, and Enterococcus species also can be found. Initial treatment: cefotaxime 2 gram IV 8 hourly. Risk is increased in patients with variceal bleed, and prophylaxis against spontaneous bacterial peritonitis is recommended when a patient presents with upper GI bleed. Another complication of cirrhosis and ascites is hepatorenal syndrome. Functional renal failure without renal pathology occurs in 10% of patients with advanced cirrhosis or acute liver failure, thought to result from altered renal hemodynamics. Two types of hepatorenal syndrome: type 1, decrease in renal function within 1 to 2 weeks of presentation, and type 2 hepatorenal syndrome associated with a rise in creatinine but is associated with a better outcome, often seen in patients with refractory ascites. Treatment: midodrine along with octreotide and IV albumin. For either type 1 or type 2 hepatorenal syndrome, prognosis is poor in the absence of renal transplantation. Thank you very much.